thank you. So I'm delighted to be here today to talk about Pre-eclampsia Redefined, and I really do believe that it's not as dry as the title might suggest. So
You all right?
Yeah.
Carry on.
Can you hear the audio?
Yeah. Oh no, I can only hear you.
You can't. Okay, so I can hear audio. I'm going to start again, and I'll just talk. If you can't hear it, then that's fine. So Pre-eclampsia Redefined. Thanks so much for the invitation today. So the traditional definition of preeclampsia is hypertension with new onset proteinuria at 20 weeks or more, which we all at this meeting appreciate. The broad definition does not mandate proteinuria, of course, but allows for other diagnostic, other relevant maternal, so symptoms, signs, or abnormal laboratory tests, or fetal placental manifestations. A broad definition was adopted by NICE in 2019 in line with the International Society, or ISSHP. But of course, any definition of preeclampsia should identify women at increased risk of adverse outcomes. And so we examine the ability of the traditional restrictive definition and broad definitions to identify the risk of adverse outcomes in two data sets. So the first was from the Fetal Medicine Foundation, and this paper is in press, the impact of new definitions of preeclampsia at term, when most women, of course, develop preeclampsia, on identification of adverse maternal and perinatal outcomes, and I present on behalf of my co-authors. Our objective was to investigate the ability of the A.Pec and the ISSHP definitions of preeclampsia to identify adverse outcomes at term, so 37 weeks or more. This was a prospective cohort study at 2 maternity hospitals in England for women attending a routine hospital visit at 35 and 0 to 36 and 6 weeks. The assessment included history and physical, of course, ultrasonographic estimated fetal weight and Doppler assessment, and angiogenic factors, specifically PLGF and SFLT. And preeclampsia was defined in one of 5 ways, which I'll show in the next slide. We looked at detection rates for outcomes of interest, and those outcomes were maternal, so severe hypertension or major maternal morbidities, so the IHOPE criteria, perinatal mortality or major neonatal morbidity, and neonatal unit admission for at least 48 hours, or birth weight less than the 10th centile. So you see here the traditional definition is defined by hypertension and proteinuria. ACOG has additional maternal manifestations identified here by the blue dots. ISSHP-M for maternal has some additional maternal criteria. I'm just highlighting here the neurological ones, or similar criteria, but more broadly defined. So an example here would be platelets, so under 150. ISSHP maternal fetal, where we use all the same maternal, but then also intrauterine fetal death or fetal growth restriction, which also incorporated definitions with abnormal Dopplers, and ISSHP maternal fetal angiogenic imbalance, which also included either a PLGF less than the 5th centile or SFLT PLGF greater than 95th centile for gestational age. So among the just over 15,000 singleton pregnancies in this cohort, preeclampsia varied by definition. So no surprise, the traditional definition was 1.8% of pregnancies. And as you increase the number of manifestations, you increase the incidence up to a maximum of 3.3%. And just to show you what was driving the preeclampsia definitions, you see proteinuria, platelets under 150, AST or ALT greater than 40, and the angiogenic markers. So they were quite important in driving it. So in a nutshell, compared with the traditional definition of preeclampsia, the ISSHP maternal fetal and angiogenic imbalance definition best identified adverse outcomes. So a busy table, but let me take you through it. Here you have the definitions. So traditional ACOG, which is maternal, ISSHP maternal, which is a bit broader, add the fetal, and then add the fetal and the angiogenic imbalance. And here are the adverse outcomes, the 2 maternal and the 3 perinatal. Highlighted in yellow are the boxes that show detection rates for that definition of preeclampsia that was significantly more sensitive, so higher detection rates than the traditional definition. So if you look here in the column, you see sensitivities for adverse maternal or perinatal outcomes that range from 41% to 72%. If you go over here on the right, you see that the ISSHP maternal fetal angiogenic imbalance definition was significantly more sensitive than for each outcome than the traditional, with sensitivities ranging from 67% to 100% for the mother and 71% to 79% for the baby. So in conclusion, our data suggests that compared with a traditional definition, a broad definition of preeclampsia can better identify women and babies at risk of adverse outcomes. And the addition of uteroplacental dysfunction to the broad definition optimizes the identification of women and babies at risk, particularly when angiogenic factors are included. So then the second data set that we looked at was the impact of preeclampsia definitions on progression to preeclampsia in the CHIPS data set, which of course was of women with chronic or gestational hypertension, again presented on behalf of a lot of work by a lot of people and in press in BJOG. So we examined the ability of the traditional definition and broad definition of preeclampsia to identify that progression to preeclampsia. We stratified our analyses by hypertension type and blood pressure control, and our main outcome measures were primary perinatal outcome and others, as well as the secondary serious maternal complications, severe hypertension, and maternal hospitalization. And what we found for the 979 women with informative data, 29% progressed to preeclampsia defined restrictively by neoproteinuria, and 48% to preeclampsia defined broadly according to maternal manifestations. The broad versus restrictive definition has significantly higher sensitivities, lower specificities, and similar or higher diagnostic odds ratios, which I'll show you in a graph in a moment. But I'll just highlight that the stratified analyses showed similar results. And when we added the available fetal placental manifestations, so stillbirth or birth weight less than the 10th centile to the broad definition, it improved sensitivities in this data set as well. So just showing you here the perinatal manifestations, just a little bit slow to change. I just want you to, the blue dots here are the traditional definition, and the red triangles, the classical broad definition. I'm just focusing on these two. We looked at some other combinations and permutations. But if you look over here at primary perinatal outcomes, you'll see that the broad definition compared with the traditional showed significantly higher sensitivity, lower specificity, and significantly higher diagnostic odds ratio. This was also true for birth weight less than the 10th centile, preterm birth, and very preterm birth. And again, with diagnostic odds ratios that were either significantly better than the traditional definition or definitely not worse. Maternal outcomes showed the same pattern. So here we see serious maternal complications, and the broad definition was more sensitive, less specific, but with diagnostic odds ratios that were similar. And that was also true for severe hypertension, as well as for hospital admission before birth. So a broad versus traditional preeclampsia definition better identifies women who develop adverse pregnancy outcomes, particularly when uteroplacental dysfunction is incorporated, and that includes angiogenic imbalance. And I just want to acknowledge the Fetal Medicine Foundation funding and funding for CHIPS, and thank you for your kind attention today.